Welcome to the Physician Associate Podcast.
Hello, welcome to this episode of the Physician Associate Podcast. My name is James. Today, I'm delighted to be joined by Amy Tullin, who is Chief Physician Associate at Epsom St Heliers Trust. Welcome to the show, Amy.
Thanks for having me.
Oh, thank you for coming on the show. I thought it'd be great to make an episode about physician associates who work in A&E because it is one of the larger secondary care specialties that has the most PAs, and I think can often be quite an attractive sort of job for student PAs to consider going into. So I thought it'd be a good idea to talk about what you do in A&E, how it works as a physician associate, some of the good points, any of the bad points that you need to consider about a career in emergency medicine, and just to let people know a little bit more about how the profession works in that specialty. So what was it that attracted you into a career as a A&E PA?
I think the thing I liked the most about being a PA, well, a student PA initially, was that you were that first person that would see that patient when they came through the door. You hadn't heard the story from anybody else, so they were fresh, and you could take that history and you could really make your own decision and make your mind up about what this differential diagnosis might be, without having any bias from anybody else. So initially, that's what kind of drew me to it. And still now, I absolutely love the team that I work with. The consultants, the nursing team, the junior doctors, all the PAs are just fantastic. And I think there's a real... it's quite a flat hierarchy or quite a flat structure within the department. So anybody from our healthcare assistants right up to the consultants, anybody can voice their ideas, or the healthcare assistant might go straight to a consultant and say, I'm really worried about this patient. Can you come with me and see them? And I found that really attractive. And I really liked that because I found on the wards it was more structured and there was more of a hierarchy. And I felt that for the patients, actually, it's much safer that anybody could raise a concern to anyone of any level. So I really like that as well. I found that really attractive. I like the fact that it's really fast paced. It can be hectic at times as well, but in a kind of a controlled manner. So I also found that really appealing. And I like with the patients, it's all about that overall picture for them. So are they really sick? In which case your job is to stabilise them, make sure that you're treating that initial illness that they've come in with, and then referring on to a specialty who will be able to give kind of more detailed care, I guess, or more in-depth care for them. And then if they're not sick, it's a case of, okay, so what do we do next? Is this something we can deal with in EM, or is this something that primary care would be better suited to sort out for them? And I just like that overall picture, the big picture for that patient. Are they sick? Are they not? Are they coming in? Are they going home? And for me, I'm not someone that often drills down to a lot of detail. So some of my colleagues work in specialties like haematology or surgical specialties, where it's very much about the detail. And that's just not me as a personality at all. So I found it really suited my personality, which was good.
Oh, thank you. I'm not sure if there is such a thing, I guess, as a typical day in A&E. But what do you do usually on your shifts? How does it work?
So it depends what you're doing, but on the whole, you'll turn up, you'll have some sort of a handover with the rest of the team, and then you'll just crack on and see the patients. So you'll usually be allocated to an area. So that might be peds for the day. That might be SDEC, which is same day emergency care, which is where the walk-in patients come in, if you like. So more stable things like chest pain or stable abdo pains. And those patients tend just to have fairly straightforward problems. So you see them and either discharge or admit. Then you've got majors where you're more unwell or more frail patients will go. And then you've got resus, which you might be allocated to as well. It depends where the need is. So sometimes you've got a 4-hour wait in SDEC, so you might be posted down there. Sometimes the wait might be in majors, so you get moved up to there. It's just dependent on the day, really. And then you will just see whatever's next in the box. And I think that's a really good part of being a PA in emergency medicine. We don't pre-select our patient group. We see anything that comes in, the same as the doctors see anything that comes in through the door. And so when you're seeing your patients, you pick up the card, you go in and see them, you take your history, you do a thorough examination, come out, look at the investigations that you've got back already. try and think of a differential diagnosis and come up with a plan in your own mind about what you think is going on. And then the next step, I guess, is fairly dependent on how experienced you are. So for me, I've been working for a long time. A lot of the patients, I know what the management plan should be, so I can crack on with that, or sort out any investigations that they might need and come up with this plan. For our more junior PAs, or even for myself, when I see somebody who's quite complex or very unwell, I'll need some more support. So in that case, that's a registrar or a consultant. A lot of the time, it will just be a discussion of, look, I have this patient with X, Y, and Z going on. Either I'm not sure what's happening, or I'm not sure about a plan. Can you help me with this? Or even now for me, it might be, this patient's got a compromised airway. I need you to physically come with me and see this patient. When you're more junior as a PA and you're starting off in EM, we say usually for the first 6 to 12 months, we ask the reg or consultant to go and physically review the patients with the PAs when they first start. I think that really helps to build the relationships between the PAs and the senior members of the team. And it really ensures patient safety as well, just to make sure those PAs haven't missed anything. And I think when I first started, I wasn't always aware, like, every single question that I should be asking for every single presentation that came in. And it wasn't until I'd worked with the consultants lots and I'd kind of learnt the craft, if you like. So when those PAs are new, we do ask for that senior support to be quite tight. And as they get more experience and as we grow happier with them and we know they know their limitations, they pull back a little bit more from them. In terms of anything else that happens in ED, in resus, you're very welcome to see your patients, get things started, run through your A to E. Again, when you're in resus, there'll be a senior doctor there to support you if you need it. But they're quite good at letting you first, make those first steps. You get started, so you feel like you've got ownership of that patient, which is another really good thing about EM, is that that's your patient, you're looking after them, you're responsible for them.
I suppose it's fair to say in A&E you could be faced with anything from a day one old baby up to a 101-year-old at the end of their life. How do you prepare for that variety? How do you transition from PA student to emergency medicine? Are there any resources that you found useful that you'd point people to? Or?
So when we first start, so for our newly qualified PAs, we tend to keep them out of PEDS for a little while, just until they're a bit more embedded in the department, they understand the processes, and they've built some working relationships with the team. When they first start as well, we give them the same induction pack that the doctors come when they rotate. So what are some high-risk presentations that you might see in ED? So these are things like abdominal pain in elderly patients, chest pain, headaches. How do you manage those conditions? You need to think about all the risks that come with those things, and how do you do those things most safely? We point them in the direction of those to get them started. And then other resources they can use, they can join RChem as an associate member, and you can link into their e-learning as well, which can give you some good resources, some good courses. And also the e-learning for health has quite a lot on emergency medicine, so that can be very helpful. But you can read as much as you want about it, but I don't think there's any substitute for just getting really stuck in and seeing as many patients as possible. And when you go home, maybe not straight after your 10-hour shift, but on your days off or during your CPD time, reflecting back on that patient that you've seen, the 101-year-old that came in with 10 different problems, and going through and reflecting back and thinking, is there anything you could have done a bit differently, or understanding the rationale behind why the medical team might have done X, Y, and Z. So I think that's a really good way to learn. And I found that as a student, revising for exams was really difficult because I hadn't seen patients with all of these problems. But once you've seen a patient with the problem, then you can visualize it, can't you? And you can make those plans and you can understand the rationale behind things a bit more. So say they're kind of the main resources, but I would just say see everything that you possibly can when it comes through the door. Don't be frightened by anything. And even with sick patients, because you will find them, they might be really obvious because you've got a pre-alert that they're coming into resus, or they might be sitting in majors and you're not, you don't become aware that they're very sick until you get in and see them, and then things change and then you have to act very quickly. So you might try and pre-select those patients, but actually you're better off just getting stuck in and seeing everything that you possibly can from the word go.
Thanks for that, Amy. You mentioned RChem, which is the Royal College of Emergency Medicine, isn't it? Have they been supportive of the physician associate profession joining A&E?
So yes, they've been supportive. I think last time I spoke to them, they had about 100 members signed up so far. They have quite a lot of ACPs as members as well. So they understand that there are non-doctor roles, which are really important in delivering patient care in emergency medicine. You can have an associate membership as well. I think it's £110 or £120 a year, something like that. And with that membership, you get access to Kaizen, which is their electronic portfolio. You get access to all their resources and discounted rates for their courses as well. And I know they've been working together with some PAs and with some consultants at looking at how they can have PAs incorporated more into emergency medicine and what they can do from their side to support them.
One of the stumbling blocks for a lot of, I guess, employers considering getting physician associates into their workforce is the lack of regulation, the lack of being able to order ionizing radiation scans like X-rays and CTs, and the lack of prescribing rights. It seems like, to me, those things would probably be problematic in A&E. How do you get around them? Is it an issue day to day in your practice?
I think it's probably an issue for most PAs, regardless of where you work in some shape or another, isn't it? In terms of the prescribing, so in our department, we're still on paper, although we are moving to an electronic system in the future. So it's a case of going to your doctor that you know and you have a working relationship with and saying, I have this patient, they have X condition, they've got pain. Do you think a paracetamol prescription would be appropriate here? Please may you prescribe it for the patient. So it's usually just a straightforward conversation like that. And I've worked with a lot of the doctors for a long time, and usually it's fairly straightforward. For our new doctors, when they rotate through, I might have a little bit of a longer discussion with them actually, because they don't know me. They don't know what level I work at. So I give them a little bit more information about that patient, because that trust and that relationship isn't there between us yet. And I'm more than happy to do that, because ultimately that risk falls onto that doctor, whoever's prescribing for you. So I think it's just a case of communicating really well with one another and working together to make sure that those prescriptions can be filled and your patients get timely treatment. I'd say in emergency medicine, though, the doctors are very used to being asked for prescriptions from the nurses. So a lot of the time, the nurses will do our triage or our streaming, and they'll say, this patient's come with really bad pain. Please, can you just sign them for some cocodamol? They've got no allergies. They're young. They don't have any comorbidities. So the doctors are used to that kind of relationship anyway. So in terms of radiology, it works very similarly in that we've had a good working relationship for a while with the doctors. So often I'll say to them, this patient's come with a cough, they're short of breath. I'm worried they might have a chest infection. Please, could you book a chest x-ray for them? And more often than not, the doctors are happy with that, and they know a bit about the patient and the case, and they know who they're ordering for if there are any problems. If it's getting to the point where that patient needs a CT, so if you've got a patient who comes in who needs a CT for trauma, perhaps, if that patient's got to the point where they need a CT, you're probably going to have a registrar involved already anyway, who knows about that patient. So I would work with that registrar, that senior doctor, to get that CT booked. It's not too much of a problem, and we're very used to it in the department now. And in terms of my working day, actually getting the prescriptions and the radiology is quite a small proportion of what I do. A lot of what I do is kind of with the admin side of things, writing the notes, seeing the patients, getting the plans together, communicating with teams. So it's a fairly small part of our role. Yes, it's irritating, but it's just how things are at the moment, and we work around it, and it seems to work okay.
What benefits have you noticed with a team of physician associates in your A&E department that PAs are able to provide?
So I think one of the real appeals that the consultants talk about is the fact that we provide continuity. although, we're not on the ward day to day, handing over those complex patients or knowing those patients inside out, it's about continuity with flow in the department and helping the team. So when we get new doctors rotating through every 4 months, they don't know how to get anything done. And that's where we really come into our own. This is how you get a CT done. This is who you talk to for this admission. This is how we get this done. And this is where that bit of equipment is kept. So that really takes a lot of strain off the senior doctors, which I think they really enjoy and they really value in us. And also because we have that continuity and we've been there for a long time, we can work really efficiently because we understand who needs to come in, who can go home, what pathways patients need to go down and what they need to get them back home again. So I think that makes us really efficient workers and really efficient members of the team.
To my knowledge, there aren't any physician associates working in the sort of pre-hospital emergency care space yet. I'm thinking ambulance-based PAs or heli-meds, those kind of things. Do you think there's a role for, perhaps as the profession grows and things change, for PAs to go into that sort of space in emergency medicine and pre-hospitally?
I don't see why not. I mean, traditionally it's been paramedics and kind of HEMS doctors, hasn't it, previously, but I don't see why not. When I first graduated, I never thought that PAs would be doing the types of things that they're doing now. I thought you would just go in, do your clinical work, go home. I didn't think there would be all these other extra roles that PAs could do. And I think especially with the GMC regulation coming in, that might open doors for us and might just open people's minds a little bit as well into the possibility that PAs can be used in different capacities, whether that's in pre-hospital medicine. I don't know, why not? I guess would be my reply to that. So obviously we do all the bread and butter stuff like catheters and cannulas, ABGs, those sorts of things. But a lot of what we do, I'd say practical skills wise, it's more around the minor injuries. So I love a good wound care case where you need to neaten up a wound and get a really good dressing on there. Like I really enjoy that part of it. Then you've got other things like joint manipulations, fracture reductions, plastering. So that's really good fun as well. And then putting on other like splints, slings. That's a really good fun thing to get involved with. The other side of things is more kind of interventional. So you've got things like fasciolaca blocks, which we use for the hip fractures. So that's a procedure that we do quite commonly. There are other things that are more advanced. I know they do in other departments, things like putting central lines in, putting chest drains in. It's not really something that we do in our department just because we're not a trauma centre and a different team tends to look after those types of interventions within the department. But I know definitely in other EDs around the country, PAs get involved in these really advanced procedures if they want to.
So we spoke about sort of additional skills you can pick up as a physician associate in emergency medicine. Are there certain qualifications or courses that people can do as well that are useful for emergency medicine?
Yes, I think off the back of the practical skills side of things, the physician associates in our trust are currently training up on ultrasound as well to have their level 1 ultrasound for emergency medicine. So this is things like fast scanning. So you use ultrasound after trauma in patients and you can look for AAAs as well. It's kind of a bedside test, but PAs can definitely get signed off to do that. There's also a master's in emergency medicine at Manchester Met University, which is open to PAs. They also offer it as a PG Cert or a PG Dip if you don't fancy the full masters. So I think that's really exciting now that we're being invited onto these courses. I definitely would recommend ALS probably to any PAs really. It's really good at building your confidence in managing sick patients. It's not just about the cardiac arrest. It's about at what point did how did you get there? And can you stop the cardiac arrest? And likewise, you've got the same for paediatrics as well. So you can do the paediatric life-saving courses, which I would find really, really helpful.
So it must be an exciting job. What are the good points about a career in A&E and what are the honestly bad points, the good, the bad, the ugly, that if you're perhaps a student physician associate and you're thinking, do I want a career in emergency medicine? What's the reality of the job?
The good thing is that it's never boring. You'll never be sat twiddling your thumbs. You'll always be busy and your shifts always go by really, really quickly. And you look at the clock and you think, oh gosh, is that the time? Because you've only got an hour left of your shift rather than, oh gosh, is that the time? Because the whole day is left to go. So it's always exciting. teamwork is a massive thing for us in ED. So it makes for a really tight team as well, that we're all really close. We've got some really good friendships within the team, and our work nights out are always a really good laugh as well, and everyone's really bonded together. You get massive variety of patients. So you might be spending the morning, you'll see a broken toe, and then in the afternoon you'll move to resus and you're dealing with a really, really sick patient that you're then stabilising. You get to make them feel better quickly, and I like that you get a really quick turnaround sometimes with your patients. You could have someone come in really bad pain, you can then be part of that team that helps make that pain better, and they feel much improved from how they did before, and that's really gratifying to see that, and people are really grateful as well for making them feel better. And they're usually very grateful when you get to send them home as well on the same day rather than admitting them into hospital. So I think that's my main things of what I really enjoy about it. The not so good sides of things are it's physically, emotionally, mentally draining, especially physically. I come home, I'm absolutely exhausted because I've been running around all day. You barely sit down. You might sit down to write some notes, and that's about it. Emotionally draining because you do see some really upsetting things that come through the door, and it's really shocking what's going on in some people's lives, and that can be quite distressing at times. And mentally draining because you are using your brain constantly. So when you're taking a history, you're constantly thinking, you're examining, you're thinking, you're trying to get your management plans together. Your mind's constantly turning, thinking about your patients and making those management plans. And doing that for 8 or 10 hours straight is really, really exhausting, actually. You don't get any downtime just to do a little bit of admin or follow up with some phone calls. There's none of that. It's just go, go, go. I think as a PA student, when you come to A&E on placement, it looks really glamorous and exciting and fun. And when you start as a PA, in reality, it's really, really hard. And I say to the team a lot of the time, you might not like this at all for the first kind of 4 to 6 months, because you will feel like you haven't got a clue what you're doing. You're really frightened. It feels really scary. And the whole thing is just really daunting. So at that point, I always say, like, reach out to anybody, talk to us constantly, be in constant kind of conversation with us about how you're feeling and what you're finding difficult. Another aspect of emergency medicine, which I do find challenging still, is having to speak to specialties all the time, because you think we're giving them patients, we're giving them work throughout the day. And although that's normal, that's what has to happen, that's the process, I still find that quite difficult sometimes, being that advocate for the patient and being a salesperson trying to get your referrals through can be quite challenging sometimes. And I'm sure for other PAs who work in specialties, even just to try and get your patient reviewed or taken over by a different team can be really tiring. And all you want at the bottom, at the end of the day, is for your patient to have good care and to go to the appropriate provider. So I find that aspect of the job quite tiring, but you have to just accept that it's kind of part of your job. You're there to be polite and to advocate for your patients, and that's all you can be. And that would be my advice to the team, that if you're having difficulty with other specialties, you just speak to your consultant or speak to your registrar, remain polite as you possibly can, and just remember that it's all for your patient, it's all for their safety at the end of the day. But on the whole, emergency medicine is amazing and it's really good fun. And I think it is a little bit addictive, that adrenaline that you get when you're at work all day. It's constant, right? What's next? What are we moving on to next? And you've got that time pressure. And I'm not sure that there's many other specialties that are like that. So it's fairly unique. And I think I don't know if you can do it for a long, long time. But I mean, I've been doing it for 9 years and I'm still going, and I still enjoy the clinical work when I go in for my shifts. Good for you. And well done on being one of the first PAs in the workforce in general in the UK, but into emergency medicine and shaping it that way. That's brilliant. If people have been listening to this episode, they may have questions. It may have fired up some ideas, or they might want to know where to go to find out more information about physician associates and about emergency medicine in particular. Where would you point people to go to find out more? So I'm more than happy for people to get in contact with myself, and they can also access the resources like Royal College of Emergency Medicine to have a look at what's going on as well. And I think just networking with PAs who work in EM in your area, if you're thinking about moving departments, it might be that you just go down and speak to people who are already working there, find out what it's like, and if there are any jobs coming up. If not, then you might be able to make one for yourself.
Perfect. Yeah, that's a really good point. I think the profession is still young enough that sometimes you can get talking to the right people and create your own destiny sometimes, can't you? You can mould what you want to do yourself. Brilliant. Thanks, Amy. Thank you so much for talking to us about physician associates in emergency medicine. I'll leave your contact details in the show notes of the episode here so people can look to find you if they've got questions. And I'll also link them to the Royal College of Emergency Medicine as well. Thanks to you for listening as well. I hope you've found it a really useful episode to find out a bit more about physician associates who work in emergency medicine. If you are a physician associate working in a really cool specialty, why not get in touch? I'd love to have you come on the podcast. Or if you've got ideas for future episodes of the podcast, please find me on social media across Facebook, Twitter and Instagram at PA Podcast UK. And I hope you'll join me again for the next episode.
Thanks for listening to the Physician Associate Podcast.